Imagine this scene, one I have witnessed countless times in the emergency room. A young man, maybe 19 or 20, walks in, hunched over and holding his stomach. He looks worried, his face is pale with a sheen of sweat. He tells the triage nurse the pain started this morning, a dull ache around his belly button. Over the last few hours it has sharpened and migrated, settling into a severe constant pain in the lower right side of his abdomen. He feels nauseous, hasn't eaten all day. A quick temperature check reveals a low-grade fever. This is a classic presentation, a story that unfolds daily in hospitals worldwide. For the nurse who first sees him, this isn't just a bellyache, it's a potential surgical emergency. This exact clinical picture is what the NCLEX aims to test. You need to think critically, prioritize actions, and anticipate what comes next. This story is more than a case study, it's a bridge from ER chaos to exam logic. By walking through his journey, from initial assessment to post-op care, we can break appendicitis into simple, memorable steps that build your confidence and help you answer critical thinking questions swiftly. The pressure in the ER is real, but core nursing principles remain constant. Recognize a pattern, ask the right questions, initiate the correct interventions, which can alter outcomes. The NCLEX will vary scenarios to test adaptability. Know the pathophysiology and the nursing process to handle any variation. To care effectively, understand what's unfolding inside. Appendicitis is inflammation of the appendix, a small finger-shaped pouch of the large intestine in the right lower abdomen. It plays a role in the immune system. Trouble begins when its opening gets blocked, commonly by a fecalith, swollen lymph tissue, a foreign body, or rarely a tumor. Obstruction traps mucus. Bacteria multiply. The appendix swells with pus and pressure rises, compressing blood vessels, leading to ischemia and necrosis. Pain begins periumbilically as referred visceral pain, then localizes as the peritoneum is irritated, to the right lower quadrant at McBurney's point. Untreated pressure can cause rupture, spilling infection and causing peritonitis, sepsis, abscess, or shock. Rapid assessment and intervention are vital. Prepare for surgery before rupture. Your assessment begins the moment you see the patient. Observe behavior. Lying still with knees to chest. Movement jolts the inflamed peritoneum and worsens pain. Guarding. Take a focused history using PQRST, provocation, quality, region and radiation, severity, timing. Classic periumbilical pain migrating to the right lower quadrant. After history, perform a focused exam. Always start with vital signs. Tachycardia, low-grade fever, inspect for distension. Start furthest from pain and move systematically. Check for peritoneal irritation, McBurney's tenderness and rebound tenderness. Rovsing sign, psoas and obturator signs support the diagnosis and demand urgent follow-up. Strong presentation guides you, but tests confirm and rule out mimics. Collect specimens and prepare for imaging. CBC, leukocytosis is common, often 10,000, 18,000 with a left shift. CRP is usually elevated. A normal CRP makes appendicitis less likely. Urinalysis helps rule out UTI and stones. For females of childbearing age, get a pregnancy test to rule out ectopic. Imaging depends on age and circumstance. Children and pregnant patients. Ultrasound first, fast, available, no radiation. An inflamed appendix is non-compressible and thickened. Ultrasound is operator dependent and can be inconclusive with bowel gas. Most adults, CT abdomen pelvis with contrast is gold standard. Accuracy exceeds 95%. CT shows a thickened, fluid-filled appendix with fat stranding and can identify abscess or rupture or alternative diagnosis. Prepare the patient, establish IV access, and explain the scan to ease anxiety. Reassurance and preparation are part of safe, patient-centered care. Once appendicitis is confirmed or strongly suspected, shift immediately to stabilizing and preparing for surgery. First priority, NPO. They will likely need general anesthesia and stomach contents increase aspiration risk. Communicate clearly to patient and family. Remove fluids and trays. Next, establish IV access and start isotonic IV fluids to restore volume and maintain pressure. Patients are often dehydrated from fever, vomiting, and poor intake. Use the IV for pain meds and pre-op antibiotics per protocol. Treat pain judiciously to avoid masking worsening signs. Do not apply heat, it can hasten rupture. Do not give laxatives or enemas. Complete pre-op checklists and ensure consent and labs are on chart. Explain simply, answer questions, reassure. Watch for sudden pain cessation followed by fever and diffuse abdominal pain, possible rupture. Act promptly. After surgery, shift to post-op monitoring and recovery. Assess airway, breathing, and circulation. Compare vitals to pre-op baseline. Slight temp rise may be normal. High fever suggests infection. Manage pain using a standardized scale and give IV, then oral analgesics. Check bowel sounds. Passage of flatus signals return of peristalsis. Laparoscopic, several small sites. Open, one larger incision. Watch for redness, swelling, warmth, purulent drainage. Monitor any drains closely. Promote mobility early. Prevent respiratory complications. Turn, cough, deep breathe, and use an incentive spirometer. Ambulation improves bowel function, circulation, and reduces DVT risk. Advanced diet as tolerated. Start clear liquids. Before discharge, teach wound infection signs, fever, increasing pain, redness, drainage, and when to call. Keep incisions clean and dry. Avoid heavy lifting for several weeks. Review medications and schedules. Confirm the surgical follow-up appointment. Use APPE NDX. Abdominal pain migration. McBurney point. Psoas. Obturator. Position knees flexed. Avoid movement. Elevated WBC and CRP. NPO. Prepare for OR. Don't heat. Don't laxatives. Don't enemas. IV fluids. Imaging. X-ray. CT. Ultrasound. The NCLEX loves what not to do. No heat. No clear liquids. No enemas. First, spot classic signs. Second, rule out UTI and ectopic. Third, prioritize NPO and IV fluids. Fourth, prepare for surgery. Fifth, watch for sudden pain relief with fever and rigidity, rupture. Nursing alert. Pain medication should only be given after a diagnosis is confirmed. Do not apply heat to the area. Heat will increase circulation to the appendix, causing further distension. Laxatives and enemas are contraindicated. If pain suddenly resolves, then systemic symptoms appear, suspect perforation and peritonitis. Priority, notify the provider and prepare for emergency surgery. By turning ER chaos into a structured plan, you master both care and questions. You're ready to recognize, prioritize, and act. This is your guide to mastering appendicitis for the NCLEX and beyond. Keep practicing clinical reasoning and you'll ace the exam and protect patients when every second counts.